Alright guys, today we're going to cover Chapter 7 in Chang's mechanical ventilation book. The chapter is titled Non-Invasive Positive Pressure Ventilation, which essentially includes CPAP and BiPAP devices. We're going to cover the physiological effects of both CPAP and BiPAP. We're going to cover the clinical applications of CPAP, and one of those applications is obstructive sleep apnea, so we're going to cover the signs of sleep apnea and its management protocols. We're also going to discuss the use of BiPAP, and we're going to discuss the characteristics of common BiPAP and CPAP interfaces. Now, when I say interfaces, I mean the masks associated with both of those devices, whether for home use or for clinical applications in the hospital. We're going to cover the clinical applications of both devices and the potential problems with the different types of interfaces. We're also going to discuss the procedure, not to exactly set up the physical interface of it, like hooking up the circuits and all that, but we're going to discuss how to set the rates and the clinical setup of the BiPAP and CPAP devices. Okay, let's get started with the physiological effects. Now, since CPAP is one pressure and BiPAP is two pressures, I'm going to talk about each of the pressures and how they relate to the physiological function. For example, IPAP is related to the peak airway pressure, which is the PIP. If you increase the IPAP, you increase the PIP, as well as you increase the tidal volume given to the lungs, which in turn increases the minute ventilation, how fast, or the amount they breathe in 1 minute. The EPAP is essentially PEEP, positive end expiratory pressure. Now, you increase the PEEP, you increase their oxygenation, as well as their FRC, which is the functional residual capacity, which is the air left in the lungs after you breathe. PEEP also helps with obstructive sleep apnea in the case that it keeps pressure in the airway, a positive pressure, which prevents the epiglottis or any kind of obstruction from closing the airway when they are breathing, hence the name obstructive sleep apnea. Now, both IPAP and EPAP can be titrated according to the patient's oxygenation and ventilation status, and that status you receive from an ABG, arterial blood gas. You can determine the oxygenation based on their arterial oxygenation, which is P(a)O2, as well as you can also look at their saturation, SaO2 or SpO2, on the monitors that they have in the hospital or clinical, or if you have a pulse ox, you can do it from there. The ventilation status you can determine from the PaCO2, the arterial content of carbon dioxide, or you can get it from an end-tidal CO2 monitor if it's attached to the patient. Using those two things, you can pretty much determine what to set, or what to increase, what to decrease, the IPAP and EPAP. Now let's go to the clinical applications of just a CPAP. Now remember, CPAP is no mechanical breaths. We're not forcing the breath to the patient. It's all spontaneous breaths. So keep that in mind with these non-invasive positive pressure ventilators. They're all spontaneous. Now, CPAP is the treatment of choice for obstructive sleep apnea, as I mentioned earlier. So it keeps a positive pressure in the airways and prevents any kind of obstruction, physiological obstruction, from blocking the airway when the person is sleeping. Now CPAP is contraindicated, not indicated, do not use for the following. Apnea due to neuromuscular causes, because again, it's spontaneous breaths. If neurologically you're not able to breathe spontaneously, the non-invasive positive pressure ventilator is of no use to you. Now, another contraindication is progressive hypoventilation. Again, if your spontaneous respiratory rate keeps decreasing, then essentially your ventilation is, you're not ventilating enough, you're not getting rid of the CO2 or taking in enough oxygen to oxygenate the tissues. Again, fatigue of respiratory muscles. If you're using your accessory muscles for a long period of time, you will essentially wear out because you can't keep up with the work of breathing that's required to keep your oxygenation and ventilation status to par. Now, since both of those, since the non-invasive positive pressure ventilators are associated with masks that go on the face, if you have any kind of facial trauma, or if your patient has any kind of facial trauma, they're not going to be able to wear the mask. So what is the use of CPAP or a BiPAP device? Same with the mask. If they have claustrophobia, if they can't be in enclosed spaces and you're putting a mask on them, it doesn't work for them. They start hyperventilating. It just doesn't work. They're not comfortable with it. Now let's go to obstructive sleep apnea. What are the signs of sleep apnea and how do you manage it? Well, sleep apnea is clinically defined as apnea greater than or equal to 10 seconds during sleep. Now, there's 3 types of sleep apnea. There's obstructive, which is a physiological obstruction. There's central, which the brain the part of the brain that sends the signals to the respiratory muscles saying, hey, breathe, is somehow obstructed, whether en route or at the centers themselves. And then you have mixed, which could be a mix of both obstructive and central sleep apnea. Now, the diagnosis for sleep apnea is done by polysomnographic study, sleep study. And the severity of it is determined by the apnea and the desaturation index. Now, the apnea index is the number of apneic episodes greater than 10 seconds in each hour of sleep during that test. So if I become apneic, let's say 20 times during that test, that is my apnea index, 20. Desaturation index. Essentially, it's the same thing as the apnea index, but it relates to your desaturations. It's the number of oxygen desaturations greater than or equal to 4% in each hour of sleep. Let's say between, say I do my sleep study between 12 a.m. and 6 a.m. in the morning, and I have desaturated more than 4 percentage points. Let's go with 20 again, 20 times. So my desaturation index is essentially 20. Now we'll go to hypopnea. That is the reduction in airflow greater than or equal to 10 seconds. That is greater than or equal to 50% of the patient's baseline. Let's say my baseline flow is, again, let's say 20 liters. 20 liters is my baseline flow when I'm sleeping. Now, when I'm sleeping, I start breathing less flows. The amount of flows that are, greater than 50%, more than half of, if I decrease my flows more than half of my baseline, that number, how many times I did that during that test, is my hypopnea index. But the apnea-hypopnea index is essentially the apnea index plus apnea index and the hypopnea index put together. The number of times I become apneic during each hour and the number of times I become hypopneic in each hour of that sleep during that test. Now we have the signs and symptoms. A lot of these can relate to all of us students. We got snoring, daytime sleepiness, restless sleep, morning fatigue, and headaches. Obviously, anyone can have these signs and symptoms, but if you have recurring signs and symptoms like this, go to get a sleep study done. They will hook you up to all kinds of monitors and figure out if you have obstructive sleep apnea or any kind of sleep apnea. Now, the treatments for sleep apnea, like I said earlier, the main thing is CPAP, continuous positive airway pressure. You can also get prosthetic mandibular advancement, or you can get surgery where they cut out part of your top palate as well as your uvula. You can also do weight loss if you're really obese, and that is the cause of your obstruction, or sleep apnea, I'm sorry. Untreated sleep apnea can lead to hypertension, left and right ventricular hypertrophy. They're working super hard. They're eventually going to wear out. Sudden, which leads to my next point, sudden cardiovascular death, and it also increases your risk for stroke because of the hypertension. Okay, now we're going to go to BiPAP. Ooh, BiPAP. Bi-level positive airway pressure. Like I said, it's got two pressures. One inspiratory, which is the IPAP, one expiratory, which is the EPAP or PEEP. The indications for BiPAP are acute respiratory failure and acute hypercapnic exacerbations of COPD. Hypercapnic, you got excessive CO2, which means you're not ventilating. Since you're not ventilating, your CO2 goes up, pH drops below, your O2 dissociation curve shifts to the left. Yeah, you have your unloading capacity is really good, but your loading capacity decreases, and all of that you can result from an ABG, which, like I said, your CO2 goes up, so it shows respiratory acidosis, and since you're also not breathing as fast, your oxygenation is also affected, so you could show mild hypoxemia there. The patients with hypoxemic respiratory failure could have refractory hypoxemia. Refractory hypoxemia is a PaO2 FiO2 ratio, PF ratio, of less than 250 millimeters of mercury. Again, you got to do the calculation, figure that out. It's not really difficult. Let's say the patients with acute cardiogenic pulmonary edema can also benefit from the use of BiPAP because it provides a positive pressure in the lungs, which can help push the fluid that's built up in the lungs from cardiogenic pulmonary edema back into the pulmonary vessels and into pulmonary circulation again. And that could also reduce the need for mechanical ventilation if caught early enough and implemented properly. Otherwise, they're going by a tube. Alright, contraindications when not to use BiPAP. When you suspect you can't protect the airway from secretions or aspirations. Again, you're putting a mask on their face. If they have a lot of secretions, you got a mask. You got positive pressure, they're gurgling it up, you the positive pressure just pushes it right back down. So again, you got aspiration issues, you can get pneumonia, you can get all kinds of stuff from that. Apneic patients, again, you need spontaneous breathing. If they're not breathing spontaneously, it's not going to work. And patients in acute respiratory distress, again, they're not ventilating properly, they're not oxygenating properly, their spontaneous breathing is going down, down, down. It's intubation is indicated for that. Putting them on a proper ventilator, an invasive ventilator. Okay, now that we've covered the CPAP and BiPAP physiological effects and the indications and contraindications of both of those, now we can go to the common characteristics of both BiPAP and CPAP interfaces, such as masks. Now there are four different interfaces for CPAP and BiPAP devices. Now the thing that makes these more difficult, the only difficulty with these that is common to all of these is different face sizes, face structures can make selection of a proper mask or an interface difficult, takes more time, it's tedious. Some therapists just don't want to do it, but good therapists should do it. Take the time to figure out what's comfortable for the patient so you can help their ventilation and oxygenation statuses. Okay, we'll start with the nasal mask. Nasal mask, like it says, covers the nose. I don't know how much more simple that could be. It's most common for OSA patients, obstructive sleep apnea patients. In there, minor leak is acceptable. Like you put it on, you don't have a good seal, you need less than 25%, less than 23% leak. If you have anything more than that, you got to move on to something else. With using just the nasal mask, the patients are much easier to comply. It's more comfortable for the patient, but the only disadvantage with that is it dries out the nose and it could stimulate nasal drainage. Okay, if the nasal mask didn't work for you, you go to the oronasal mask. Oronasal, it covers both, like the Bane mask. I wish they had one, that's pretty cool. You get a better seal than a nasal mask because, again, it covers the entire region. It provides more effective ventilation because if you have just a nasal mask, they can still breathe through their mouth, so that doesn't help with maintaining the pressures that you need. The disadvantages are, again, if they're claustrophobic, it can decrease their compliance since it's an entire mask. It covers your nose and your mouth. Some patients aren't compliant with it. It's you've never used that. Somebody just suddenly says, "Hey, got to put on a mask for 6 to 8 hours a day just so we can help you." You're like, "Hey, whoa, hold on." All right. Then if you, again, like I said, with the aspiration and regurgitation, they vomit. You got a mask on, they vomit. They're just gonna go right back. It's not good for them. Again, because pneumonia. You don't want that. Aspiration pneumonia, especially from gastric juices, ooh, that can get bad quick. Asphyxiation due to input failure. Like if they have the mask on, you got a complete seal on them, but then you somehow, I don't know how that would happen, without any kind of alarms going off, but you have the oxygen tubing that comes out from the wall. It just somehow comes out. They're not getting oxygen, they're not getting any kind of air, room air, that's just blowing into them. Or if you have a power loss. If you have a power loss, it's on there, but now some masks have a quick release. The patient can just, take it off a lot easier. But still, that doesn't prevent complete asphyxiation in 100% of the patients, 100% of the time. So that's why monitoring is really necessary along with alarms. Okay, now we go to nasal pillows. Now they're more common with CPAP therapy. Now, when I say CPAP therapy, don't get confused. Be like, hey, I thought the nasal mask was just for OSA patients that are using CPAP. This is for just CPAP. Doesn't mean they have to have obstructive sleep apnea. It just means they need some sort of continuous positive airway pressure for whatever problem they have going on. It could be due to oxygenation or ventilation, whichever. The nasal pillows are more comfortable for the patient compared to the other interfaces because it doesn't cover anything. It's just boop, right there, and it goes all the way back. I'll put pictures somewhere so y'all can see those. But again, it's prone to leaks, nasal dryness, drainage. You can have rhinorrhea, which is a fancy term for nosebleeds. Then you can have the full face mask, like the Freddy versus Jason mask Mr. Porter's always talking about. They're easier to fit with patients. The patients that have claustrophobia, they can handle that better. You have less hassle with air leaks and facial traumas. Okay, now the procedure to set up and titrate the CPAP and BiPAP settings. Now, this is pretty much what settings would you start? Okay, doctor orders 12/8. Mohammed, go set up patient X on 12/8. All right, doctor, I got it. So what would you start them on? Let's say they're on CPAP. Well, 12/8 wouldn't be CPAP. They just say CPAP of 6. Let's just say 6. 6 centimeters of water. So you start at 4. Start at 4 centimeters of water and then titrate up according to the patient's comfort. Let's say you get there, you titrate up to 6, but the patient can't handle it. They're screaming, wailing around, hey, I can't handle it. So talk to the doctor, lower it back to 5. If they can handle 5, leave them on 5. Go talk to the doctor, be like, hey, they're not able to handle it. If the doctor says, hey, suck it up, tell them to get over it. So you go back in there, coach the patient, see if you can get them back to that 6 that they ordered. If not, doctors are reasonable. They'll knock the order back down to 5. Now, some CPAP machines are auto-titrating, which means you can't, there's no setting for them. It titrates based upon the patient's need, their ventilatory flows, patterns, their pressures. They're mostly used for long-term home care, and they can be unattended because they've been fitted, I guess, for that specific patient. Now, unattended auto-titrating ones should not be used for central sleep apnea because, again, they can go apneic on you. It's their brain's fault. It's not an obstruction causing it. So they can go apneic and it can be dangerous for them. Now you have a ramp setting that you can do on the CPAP machines, which basically means it will ramp the pressure up to a specific point, which is either tolerable for the patient or a preset pressure. It can do it. It spreads the pressure over time, normally about 45 minutes. Then you have C-Flex. The main problem with patients on CPAP and BiPAP is that it's hard to exhale against that positive pressure. So C-Flex is pressure relief during exhalation. There's 3 available levels. I'll put a picture up so you can visualize that also, maybe over here somewhere. Okay, now we go to BiPAP. BiPAP, you normally start at 8/4. 8 is the inspiratory pressure, the IPAP, and then the 4 is the EPAP, the expiratory pressure, or PEEP. And then you titrate up. Again, let's go with the first scenario. Doctor orders 12/8 on patient X. I go set it up. Don't immediately start it on 12/8 because that flow, that pressure, that initial pressure might be too great for them to handle, especially if they've never been on a BiPAP before. So start at 8/4. 8 is the IPAP and 4 is the EPAP. And then titrate up according to the patient's comfort level and what they can handle. again, the BiPAP has the same feature as the CPAP, the Flex technology. BiPAP is called BiFlex. So it provides not only pressure during exhalation, but also pressure relief during inhalation. So it's easier for them to take a breath in as well as exhale against the pressure. Okay, let's see what else we got. And I believe that is all for non-invasive positive pressure ventilation, Chapter 7 in Chang's mechanical ventilation book. I guess if you guys have any comments or concerns, you can comment below. If you want, you can hit subscribe. That'd be awesome.